So in follicular lymphoma, the choice of which PI3 kinase inhibitor is, I think, largely driven based on a few fundamental issues. One, are you looking for an IV formulation or are you looking for an oral formulation? The IV would push you towards, obviously, towards copanlisib, oral either duvelisib or idelalisib. With regard to some of the other comorbidities, if someone was a diabetic, you kind of want to stay, or had problems with hypertension, you probably want to stay away from copanlisib and use one of the oral inhibitors. We do not have comparative trials between duvelisib and idelalisib to definitively say which one is better in terms of some of the adverse event profiles. Although if you look at the package inserts, there are some differences in terms of that, and that might lend you to use one over another. I think one of the most important issues for PI3 kinase inhibitors is trying to manage the adverse event profile. We know that these drugs have tremendous efficacy, but they also come with some baggage of some adverse events. Some of the infectious complications, some of the autoimmune complications such as colitis and liver function abnormalities. So trying to find ways that improve the safety profile is, I think, paramount. We know that in some studies that dose reduction has led to patients staying on drugs for longer. In my own patient population, I know when I've had to dose reduce patients that I've been able to sometimes to keep people on drug for many years at that reduced dose. And so I don't try to dose escalate for the vast majority of patients because they seem to have the same efficacy. But you have to wonder whether a different schedule is important. We know what giving continuous PI3 kinase inhibition does, but perhaps we should be using alternative schedules such as every other week, 2 weeks on, 2 weeks off. Maybe it should be an induction dose followed by a reduced dose afterwards. Maybe this would allow us to use these inhibitors more broadly. So if we know that if we're going to get the most out of these PI3 kinase inhibitors, we have to be able to use them earlier in the natural history of this disease. And so finding strategies that allow us to use them earlier, such as those just outlined, are really important. I think there are also a number of questions that are unanswered with PI3 kinase inhibitors. They're approved now for the treatment of low-grade lymphoma. They're approved for the treatment of chronic lymphocytic leukemia. But some of these PI3 kinase inhibitors might be useful in other malignancies. For instance, we know with duvelisib there's good data in T-cell malignancies that might broaden its applications. You could wonder whether they also might be useful in diseases such as mantle cell lymphoma, specifically whether the inhibiting the alpha isoform is important, such as copanlisib might be useful there. So there are many different questions that need to be answered, not on how making these regimens more tolerable, but on using these regimens in other malignancies to broaden their application.